Today I will be presenting on language and cognition in Huntington's disease. The purpose of today's presentation is to explore how speech-language pathologists manage language and cognition in Huntington's disease in the acute care setting. Huntington's disease is a neurodegenerative disorder that has profound effects on an individual's ability to communicate. A summary of sources were reviewed to discuss important information regarding Huntington's disease. A further discussion will be described on how this disease affects the communication of individuals with Huntington's disease. As a speech-language pathologist, understanding our role within the acute care setting is important when managing language and cognition in Huntington's disease. Hamilton defines Huntington's disease as a hereditary neurodegenerative disorder with progressive motor, cognitive, and neuropsychiatric impairments, which can have a profound effect on the ability of the individual with Huntington's disease to communicate. Huntington's disease is caused by an inherited defect in a single gene, which I will go into detail in the next section. The symptom onset typically occurs at 20 to 50 years of age. The symptoms that are associated with Huntington's are language and cognitive impairments, dysarthria, dysphagia, uncontrolled movements, bradykinesia, which is the slowness of movement, rigidity, which elicits start-stop movements, anxiety, and depression. I will go into further detail about these symptoms throughout this presentation. There is no known cure at this time for the disease. Huntington's disease was first recognized by George Huntington in 1872. Huntington's chorea was the original term. Burge defines chorea as a neurological disorder characterized by involuntary, jerky movements that affect certain parts of the body. Throughout the 18th and 19th centuries, chronic adult hereditary chorea was poorly understood because people who had the Huntington gene died before the symptoms could develop. Now that we live longer, the Huntington gene has more time to express itself. The discovery of the gene that caused this disease was found in 1993, which was a major milestone in Huntington's disease. I will now talk more about the genetic component relevant to this disease. Hamilton goes into further detail on how the Huntington gene provides instructions for making a protein called Huntington. Mutations in the Huntington gene cause Huntington's disease and involves the DNA segment known as the CAG trinucleotide repeat. This trinucleotide is located on chromosome 4. However, on individuals affected, the CAG sequence is expanded, leading to brain cell dysfunction and neuronal death primarily in the basal ganglia, but also in the thalamus and the cerebral cortex. This single gene disease follows an autosomal dominant inheritance affecting both men and women. Each offspring of an affected parent has a 50% risk of inheriting the gene mutation and developing the disease. Because I will be talking about how to manage cognitive and language defects in the acute care setting, I will mainly be focusing on the cognitive and language deficits associated with this disease. In terms of cognition, Murray describes disturbances of attention, memory, executive functions, and visual spatial skills in Huntington's disease. Language deficits include comprehension deficits such as difficulty processing sentences with complex grammar, discourse complexity, perseveration, word-finding deficits, and a decreased length of utterance. There is no treatment to stop or reverse Huntington's disease. However, there are some medications that can help symptoms stay under control. These drugs include tetrabenazine, antipsychotic drugs, and antidepressants. A variety of symptoms can affect communication, and no single course of treatment will be effective throughout the disease. A recent systematic review by Fisher in 2015 stated evidence in success with sensory input when there is peripheral input abnormalities to the central nervous system. Maintaining communication from the early stages is important, and speech language therapy goals should include maximizing compensatory strategies and will vary based on supportive, informative, and facilitative management. Behavioral management was also associated in the reduction of aggressive behaviors in individuals with Huntington's disease. Now I will discuss the clinical implications with Huntington's disease and how it is related to speech-language pathology. The part of the brain most affected by Huntington's disease is the basal ganglia, which organizes muscle movements of the body. Here is a picture of the basal ganglia, and here is a picture of the basal ganglia affected in Huntington's disease. Because of cell death within the basal ganglia, thalamus, and cortex, there are profound motor effects that affect motor control and executions of tasks such as chorea, rigidity, which elicits start-stop movement through the range of motions through a joint, bradykinesia, which is the slowness of movement, dysarthria, dysphagia, and dystonia, which is the abnormal contraction of muscles and walking difficulties. So how does this affect the function of speech and language? As the disease progresses, frontal regions of the brain may be damaged, interfering with the ability to process thoughts, speech disorganization, and it can cause personality changes. In the early stages of the disorder, cognitive dysfunctions in attention, concentration, visual spatial abilities, emotional processing, and immediate memory become more apparent, but again vary in their evolution over time. They often have a lack of awareness of their deficits, also known as anosognosia. At later stages of the disease, patients exhibit deficits in executive functioning, especially on tests that require planning, problem solving, cognitive flexibility, and freedom from distraction. Short-term memory, episodic memory, working memory, and procedural memory are affected in the later stages. Anxiety and depression are a major component of Huntington's disease. All of these effects can affect someone's quality of life and the family's quality of life. These kinds of cognitive changes make it difficult for a person with this disease to complete simple tasks throughout the day, and therefore they present challenges related to their care. Learning to develop clear, appropriate communication strategies to assist the person throughout activities is imperative in allowing them to maintain independence for as long as possible. This disease has a major impact on language. They typically have high-level comprehension deficits that cause difficulties in processing sentences that are grammatically complex. These patients have word-finding deficits, trouble with confrontation naming tasks, and verbal fluency tasks. They have decreased syntactical productions and have trouble understanding complex topics and inferencing. Due to the motor effects to the muscle movements, these individuals have trouble with writing, which can also affect one's quality of life. Because of the progressive nature of this disease, it is important as speech-language pathologists to train communication partners about the changes in cognition and language with their loved ones. It is also important to use simpler language and possibly provide alternative communication devices to these individuals and their families to encourage continued communication. This is the acute care model, and we have to keep this in mind when treating a patient. The patient and family are the most important component in this model. It's important to understand how us clinicians can manage these patients, and Huntington's disease can cause a length of stay in the hospital. Huntington's disease can cause aspiration pneumonia, self-harm due to suicidal thoughts, and other infectious diseases that may cause admission to the acute care setting. A key component of the acute care model is educating and respecting family wishes. This is something to be aware of. With the case of Huntington's disease, educating family about the use of other communication systems such as an AAC device or other types of low-tech devices or strategies may be an important component. SLPs in this setting mainly evaluate, diagnose, and educate patients with Huntington's disease about their swallowing, language, and cognition. To assess problem solving, caregivers in the facility should frequently talk to the person with Huntington's disease about possible problems they may encounter and how to react. For example, asking them what to do if they need to talk to the nurse or how to go to the bathroom would be tasks to assess cognition. It is good to work on situations in a functional way before the problems worsen. Safety comes into play when their cognition is affected, and that's an important component in the ACM model. Memory in acute care can be assessed, for example, saying the name of yourself as you walk into the room and waiting 5 minutes to ask them what your name is also a good short-term memory strategy. Educating the patient and family on incorporating a schedule or a calendar can establish a routine specific to that patient. Language samples can be formally or informally assessed and managed in acute care. It may be feasible to administer tasks such as the Boston cookie theft or grocery scene pictures to assess verbal language. Assessing one's ability to write out names and cards is a functional way to incorporate reading and writing. Assessing language in a naturalistic way by naming objects in the room and having them follow one-step commands is something that can be done to evaluate their processing. As an SLP in the acute care setting, assessing one's ability to feed and swallow is essential, and advocating for possible swallow studies may be needed. Due to the motor deficits in Huntington's disease, swallowing and feeding is a huge portion that needs to be assessed. Being aware of cost effectiveness and ethical issues are also a component that SLPs need to be cautious of. The psychosocial impact of the patients must be taken into consideration, especially due to the anxiety and suicidal thoughts that arise. As noted before, there is no known cure. As SLPs, we want to encourage this patient to speak clearly and take a deep breath before speaking. Using an AAC device and using other functional skills, such as gesturing, would be compensatory strategies that this patient can use. If someone can't think of a word, we can ask them to just describe it. It's important for SLPs to keep the patient's interests in mind as well as their quality of life, because that essentially is the key in managing their comfort, health, and happiness. SLPs have to keep the acute care model in mind when treating Huntington's disease in this setting. In conclusion to this presentation, Huntington's disease is a neurodegenerative disorder with progressive motor, cognitive, and neuropsychiatric impairments, which can have a profound effect on the ability of the individual with Huntington's disease to communicate. Their cognitive deficits include problems with attention, short-term and episodic memory, visual spatial skills, and executive functions. Their main language deficits are word-finding deficits, writing problems, comprehension of complex sentences, and a decreased production of sentences. Other issues in Huntington's disease include motor problems, chorea, which is involuntary movements, dysarthria, and dysphagia. The clinical implications for Huntington's disease include speech, language, cognition, and swallowing, with an emphasis on language and cognition for this presentation. Working with these patients means that we have to treat their quality of life and maintain the whole patient as a person. Thank you.